Welcome to AZIN's Guideline Updates, Episode G7, DKA and HHS. I am Dr. Z. KC is here. Educational only, not individual medical advice.
Dr. Z, how many of us learned the 2009 DKA algorithm and have been using it ever since?
Laughs most of us. The 2024 Consensus Report, published in Diabetes Care in August 2024 and endorsed by 5 major diabetes societies, is the first major update since 2009. 15 years, and it resolves questions that have been generating hospital arguments for years.
I will be honest. I learned DKA, insulin drip, ICU, and HHS, push fluids, check glucose every hour. Are either of those still right?
Partly. The ICU for all DKA is now challenged by the new severity classification, and HHS finally has formal resolution criteria, which is something that has never existed before.
Let us start with the DKA severity classification.
New 3-tier system based primarily on beta-hydroxybutyrate, pH, bicarbonate, and mental status. Mild DKA, BHB 6 or below, pH above 7.25, bicarb 15 or above, normal mental status. Moderate, BHB 6 or below, pH between 7.0 and 7.25, bicarb 10 to 14, normal or drowsy. Severe, BHB above 6, pH below 7.0, bicarb below 10, stupor or coma. Level of care is assigned by severity.
So mild DKA with a normal mental status does not automatically go to the ICU.
Correct. Mild, uncomplicated DKA can be managed on a general floor or observation unit. Moderate may go to step down. Severe or DKA with critical illness comorbidities or HHS with significant neurological findings goes to the ICU. This is a meaningful resource allocation change for hospitals.
And beta-hydroxybutyrate. The 2024 consensus says this replaces the anion gap as the primary monitoring tool?
As the primary diagnostic and monitoring tool, yes. BHB is more direct than the anion gap. It does not require calculation, and it is not confounded by other gap-causing conditions like renal failure or lactic acidosis. Bedside or point-of-care BHB testing is preferred. You check it every 4 hours during treatment until the DKA resolves.
What is the BHB threshold for DKA resolution?
Below 3 millimoles per liter, combined with pH normalization and clinical improvement. Anion gap normalization remains an acceptable surrogate if BHB testing is not available at your hospital.
What about SGLT2 inhibitors? I heard there is a euglycemic DKA issue.
Important. SGLT2 inhibitor-associated euglycemic DKA. The glucose may be below 200 milligrams per deciliter, so the classic diagnosis of DKA by glucose level alone will miss it. In patients on SGLT2 inhibitors who present ill, screen with BHB even if the glucose looks okay. The consensus addresses this specifically.
Now subcutaneous insulin for DKA. This felt revolutionary when I read about it.
It is available as an option for mild, uncomplicated DKA and select moderate cases in patients who are hemodynamically stable, have adequate oral intake, and can be monitored reliably. Rapid-acting insulin analog at 0.1 units per kilogram every hour or 0.2 units per kilogram every 2 hours. Outcomes are comparable to intravenous insulin when fluid resuscitation is adequate.
What are the requirements on the nursing side for this to work?
Reliable monitoring, adequate floor access for fluid administration, nursing competency, and a floor that can do hourly assessments. This is not a universal option. If the floor does not have the infrastructure, the 4-insulin protocol remains the safer choice. The goal is not to move everyone off the ICU with subcutaneous insulin. The goal is to not reflexively escalate mild DKA to intensive care when a well-monitored floor can handle it.
HHS. What is new?
2 things. First, the diagnostic criteria have been updated. The bicarbonate threshold was lowered from 18 to 15, which allows for mild acidosis in HHS patients. A new criterion, total serum osmolality, was added. Second, and this is the big one, for the first time ever, there are formal HHS resolution criteria.
Resolution criteria. I genuinely did not know those did not exist before.
They did not. The old approach was basically glucose is coming down, looks better, we're done. But premature transitions in HHS lead to relapse. The new resolution criteria involve normalization of serum osmolality, glucose below 200, and mental status restoration. You need all of those, not just a glucose number.
Potassium. Walk me through the three-tier protocol.
Tier 1. Potassium above 5.0. Do not give supplemental potassium and do not hold insulin. Tier 2. Potassium 3.5 to 5. Proceed with insulin but replace potassium concurrently. Tier 3. Potassium below 3.5. Hold insulin. Replace aggressively before starting. This is not new in concept, but the 2024 consensus streamlines it. Check potassium before you start insulin. That is the rule.
Basal insulin. What does the consensus say?
If the patient was on basal insulin at home, continue it at the usual dose during the hospitalization alongside the insulin infusion or subcutaneous protocol. Do not just stop it at the door. Continuing basal insulin reduces rebound hyperglycemia and the risk of recurrent DKA when you transition off the 4 insulin.
What about the discharge piece?
The 2024 consensus gives this a B recommendation, meaning it is based on evidence. Before discharge, every DKA and HHS patient must receive education. Injection technique, glucose monitoring, ketone testing, sick day rules, who to call when to come back. Studies show a significant proportion of DKA hospitalizations are preventable with sick day rule adherence. The education is not optional. It belongs in the discharge summary explicitly.
3 take-homes.
1. BHB at bedside is now the primary diagnostic and monitoring tool for DKA. Order it on admission and every 4 hours. 2. Mild DKA does not require the ICU. Use the new severity classification to assign level of care. 3. HHS has formal resolution criteria now. Do not just transition when the glucose looks okay.
G7 done. Next is G8. Pulmonary embolism. The first ever AHA/ACC-PE guideline.
It is a significant one. 5 new categories, outpatient PE guidance, TEF follow-up. See you in episode G8 on AZENS.